Hello, good morning, participants. Please, anyone ready with his presentation can start sharing his slides. Dr. Ekele Robert, you were given a question. If you are ready, you can start sharing your slide. Excellent.
Good morning. Hello, Chief. Good morning.
Yeah,
can you
morning.
hear me?
Yes.
Okay. It's my own network. I can't hear you very well. Okay.
Okay, we can hear you clearly.
Okay.
Yeah.
Okay, so can I start? Or I should wait a little?
No. By 7, maybe 7:02 or 01. Let's wait for more participants. Yeah.
All right,
Dr. Robert, well done. I love your fire, your ginger. Keep it up.
Chief, good morning, ma.
Dr. Fatima, good morning.
Good morning, ma.
I love this. Please keep it up. Dr. Robert, I believe you are going for this exam.
I'm going in October.
Are you serious? This your spirit of fire is good though. Keep it up.
Okay, ma.
Well done.
Okay. I don't know where to.
Dr. Fatima.
Yes, ma.
You can start. You can introduce and start.
All right. Good morning, Chief Bansi, Chief Christabel, Chief Remigos, and all our chiefs present. Good morning, participants. My recording is not started. Yes.
There's recording.
Okay. So good morning, all participants. Today we are starting the second round of our class. Sorry, first round. We are starting with Africa, October 2023, and we'll be taking question 2 by Dr. Ekele Robert. Dr. Ekele, you have the floor, please.
Good morning, my consultants and colleagues. This morning I'll be discussing question 2 of WACP October 2023. Okay. I hope you can see the slides. So this is the question. Mr. A 45-year-old man, presented to the accident and emergency department with sudden onset of left-sided body weakness and facial weakness while passing urine at night. He had a prior history of severe headaches to the onset of symptoms. He's a known hypertensive for 1 year with poor drug compliance. He doesn't smoke or take alcohol. However, he consumes marijuana and cocaine occasionally. His father and elder brother were both hypertensive and died of stroke. His blood pressure representation was 220, 120 millimeters of mercury, and the pulse rate was 60 beats per minute. So these are the questions. List 4 differentials and 6 causes. Describe your findings in the image, and then list the other investigations you would order for and why. Discuss your principle of management and what are the risk factors in this patient. So the other differentials that may be considered include acute right hemispheric ischemic stroke, acute right hemispheric hemorrhagic stroke, acute ruptured aneurysmal subarachnoid hemorrhage, reversible cerebral vasoconstriction syndrome, then intracranial space occupying lesion with intertumoral bleed, hemiplegic migraine, that's an acute phase, and then transient ischemic attack. And then for the causes, is a young man, most common cause is atrioventricular malformation. Then you can consider Moya disease. You can consider hematologic causes like sickle cell disease, hemophilias, HIV, syphilis, cerebral amyloid angiopathy. That's the most common cause in the older adults. Okay, you can consider the vasculitis, Takayasu arteritis, SLE, Visual's disease, rupture of an aneurysm, then altered hemostasis, like when you have patients who are on prolonged anticoagulant therapy, bleeding dialysis, cavernous angiomas, and a cerebral venous thrombosis. You can also consider the inherited stroke syndromes like Fabry's disease, CADASIL, CARASIL, Pontian autosomal dominant microangiopathy, and leukoencephalopathy. Then even the mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes as MELAS. Okay. Then these are the risk factors: uncontrolled hypertension, modifiable risk factors are uncontrolled hypertension, obesity, alcohol use, cocaine use, like we saw in this patient, marijuana use, smoking, dyslipidemia, and diabetes mellitus. Then the non-modifiable risk factors like male sex, he's male, he's black, he has a family history, and then older age is also a risk factor. Then I got this, so potentially modifiable risk factors like carotid artery stenosis, nephrotic syndrome, or the hypercoagulable states. Then the second question was describe your findings in the image. So it was a an axial CT scan of the brain showing an area of hyperdensity in the right basal ganglia with surrounding loss of gray-white matters differentiation suggestive of cerebral edema. And then there's associated midline shift with near complete effacement of the right lateral ventricle. I think that would be a way to describe it. Then other investigations that you would do, this person is hypertensive, so it's nice to just investigate him. Do ECG where you may see features of, although they said 1 year, it's possible that he may have been hypertensive before then. Maybe you could see things like LVH, see arrhythmias or chamber enlargements, do a lipid profile, which may reveal dyslipidemia. It's good to check his kidney function, because we know that renal could have hypertensive nephropathy. It's good to screen for infectious diseases like HIV, even syphilis. Do a full blood count, ESR. It's good to do an echo to look at the structure of the heart and check if you see any other abnormalities. It's good to screen for diabetes mellitus, do a fasting blood sugar, and the request for hemoglobin A1C. Also do a chest X-ray to watch out for other complications that could occur in stroke, like aspiration pneumonitis. Then for considering the inherited stroke syndromes, could do genetic testing. Urine toxicology is a young man, and just like I said, he takes he abuses substances. So it's also be nice to do a thyroid function test if you got history relating to to that because it's said that in hypothyroidism, you could have a hypocoagulable and hyperfibrinolytic state, then clotting profile. You can also do culture, because infection is one of the complications of stroke. So the next question was discuss your principle of management. So for pre-hospital care, it's nice while the patient was still at home, so you should try not to force feed, make sure his head is elevated, and then try to bring him to the hospital quickly. Adequate hydration is important with isotonic intravenous fluids, oxygenation, if SpO2 is low, and it also helps with management of elevated ICP. Then blood pressure management is very important. The blood pressure here was really, really elevated, so it's been nice to give intravenous beta blockers like labetalol, can even use calcium channel blockers and other antihypertensives and target a systolic blood pressure of 140 millimeters of mercury. It's good to maintain normal glycemia, make sure that it doesn't have hypo or hyperglycemia because there are bad prognostic factors in stroke. Maintain optimal body temperature, sure that it doesn't have fever. Can do a swallow test. And if it fails it, then you go to pass an NG tube for feeding and medications. It's good to do prevention and treatment for DVT or pulmonary embolism. You can use an intermittent pneumatic stocking or TED stockings. And then there are some cases where you could even consider anticoagulation. Then prevention and treatment of other complications that may arise. Then early rehabilitation and mobilization is important. Early institution of physiotherapy. Okay, your goals of management will be to minimize the extent of the brain injury, to prevent, that's your overall goal of management, to prevent the recurrence of a stroke, and then to prevent and treat acute neurological and systemic complications. Okay, so what were the risk factors in this patient? He had uncontrolled hypertension, is hypertensive and had poor compliance. He abused drugs, marijuana and cocaine, and he had a family history of hypertension and stroke in the father, and the elder brother, he's male, and he's of the Black race. Okay, so that's the question. So I'll just try and in the next 5-6 minutes, let me just rush through the slides I prepared. So ICH, also known as hemorrhagic stroke, is a sudden bleeding to the tissues of the brain. It encompasses intraparenchymal bleed and also intraventricular hemorrhage. Is a type of intracranial hemorrhage. It's second after ischemic stroke. So it affects males more than female, older adults, and affects Blacks more than whites. And then the 30-day mortality is about 35 to 52%. And most of the deaths occur within the first 48 hours. Okay, so the etiology, I've mentioned this before, so I won't talk about them again. So that's on the pathophysiology. What happens is basically there's a problem with the blood vessel wall, that's the vascular wall. So either it could be traumatic and non-traumatic. So there's a problem with the wall. So either there's a tear or there's a leak. So most occur from hypertensive damage to the blood vessels. There also could be autoregulatory dysfunction when there's excessive cerebral blood flow. Could be from rupture of an aneurysm or intravenous malformation. There could be altered hemostasis in, like when you have patients on anticoagulants or hemorrhagic necrosis. Could be due to venous outflow obstruction. Okay, so the chronic hypertension produces small vessel vasculopathy, which could lead to development of Charcot-Bouchard aneurysms. It affects the penetrating arteries throughout the brain, including the lenticulostriates and others. And then the predilection sites for intracerebral hemorrhage include the basal ganglia first, then the lobar regions, that's talking about the temporal, thalamus, the pons, cerebellum, and other brainstem sites. For non-penetrating and penetrating cranial trauma is also a cause. Patients who experience blunt head trauma and then receive warfarin or clopidogrel at increased risk for intracranial hemorrhage. IVH also occurs in about a third of cases. And then sometimes we will have isolated intraventricular hemorrhage. So the clinical features, you could have altered level of consciousness, headache like you had in this patient, nausea, vomiting, seizures, and then different focal neurological deficits like this patient had hemiparesis. And then for lobar hemorrhage due to cerebral amyloid angiopathy may be preceded by prodromal symptoms of focal numbness, tingling, or weakness. On examination, you may see a markedly elevated BP, hyperthermia, local rigidity, altered level of consciousness, and anisocoria. And then some focal neurologic deficits you see depending on the area of the brain that is affected. Like if it affects the putamen, would get contralateral hemiparesis, contralateral sensory loss, contralateral conjugate gaze paralysis, or homonymous hemianopia, aphasia, neglect, or apraxia. If it affects the brain stem, you could have quadriparesis, especially when it affects the ventral pons, facial weakness, ocular bobbing. When it affects the cerebellum, you could have ataxia. And gaze paralysis, Q deviation, meiosis. Okay, so these are the differentials. I've talked about them, so I won't mention them again. Head injury, subdural empyema, herpes simplex, encephalitis, CNS melanomas. Okay, for investigations, you do the first usually imaging. Usually request for non-contrast brain CT or MRI, and then sometimes it's when it affects the larger blood vessels, you can request for CT angiography or magnetic resonance angiography, or you could do a conventional catheter angiography. Okay, I just added these images that we can look at later of bleeds in different parts of the brain. So I just look at it when we get the slide. Okay, so like this temporal bleed, the one on the right, and then cerebellar bleed and IVH. These are MRI images of bleeds to different parts of the brain. Okay, this talking about the appearance of the hemorrhage on MRI. In the hyperacute phase, you get an iso or hypo intense image. The acute phase is also iso or hypo intense, and then at least after 3 days, it becomes hyper because the hemoglobin, mainly be methemoglobin, but in the chronic, it becomes iso or hypo dense again. Okay, so these are the investigations. I think I've talked about them earlier, so that I won't mention them again. But in rare occasions, we do a lumbar puncture or histology. Okay, so the goals of treatments, like I mentioned earlier, is to prevent hemorrhage expansion, monitor and manage elevated ICP, and then manage other neurological or medical complications that may arise. So I've talked about the blood pressure control. Let me also add nursing care is very important. Serial neurologic examinations, DVT prophylaxis. It's good to identify comorbidities and complications and treat them with, for example, antibiotics, anti-seizure medications, insulin, antipyretics. For those with GCS less than 8, better to manage in the ICU. And sometimes some people use recombinant factor 7 to try to.
You have 2 minutes to conclude.
2 minutes. All right, thank you so much. Okay, so in some situations you may consider surgery. Okay, you do craniotomy or stereotactic aspiration. Okay, so I just added, okay, that's actually the end of the presentation, but I just added the slides that we can look at later. So you have spontaneous ICH, you do a CT, and then with history of high risk factors, go ahead and do a CT angio, and if you get a bleed, you can go ahead and do a high yield digital subtraction angiography. So we can look at this list later. That's the ICH scoring. So the higher the score, the worse the prognosis. This is how you calculate. In the second category, you have the ICH volume of greater than 30 cm or less than 30 cm. So this is how you calculate it. Okay, there's also an IVH score. The higher the score, the worse the prognosis. And then this is a modified Rankin scale. Okay, I also added some tables from the American Heart Association and American Stroke Association guidelines. So later we can look at it. This table talks about blood pressure control, very important. Try not to reduce systolic less than 130. For those who were on aspirin before they had the stroke and they request surgery, can do platelet transfusion. Okay, this talks about the for those who were on anticoagulants before they had the stroke, some reversal medications that you can use. The 4F is 4-factor prothrombin complex concentrate, contains factor 10, 9, 7, and 2. I used the code 1972 to remember that. Okay, so inpatient care, it's very important to pay close attention to the patients. Then for patients that with suspected seizures or confirmed seizures, you can use anti-seizure medications. But if there's no seizure at all, don't bother with anti-seizure medications. Therefore, the table 5.5 says for patients with risk ICP, you should use osmotic diuretics. And then surgical intervention, MI is minimally invasive surgery for those with supratentorial ICH of greater than 20 or 30 mil, and then GCS scores within the range of 5 to 12. You can do minimally invasive hematoma preferred over the conventional craniectomy. Okay. Okay, so the complications in the acute phase, you expect aspiration, pressure sores, dysphagia, hypoglycemia. In chronic phase, can expect contractures, cognitive impairment, post-stroke seizures, depression. And then the prognosis, early reduction in the level of consciousness carries a bad prognosis. Larger hematomas have a worse prognosis. And then larger hemorrhage that's a lobar hemorrhage has a better outcome than deeper hemorrhages, like subcortical. Then there's significant volume of intraventricular blood is also a poor prognostic indicator. And then the presence of hydrocephalus also portends a poor outcome. So prevention, educate the patients, ensure good BP control and glycemic control, educate people on the avoidance of alcohol and substance use and lifestyle modification. So in conclusion, ICH is an emergency. Like we all know, remember the slogan, time is brain. The most common sites for arterial hemorrhage are the putamen, chordates, nucleus, pons, cerebellum. And then prompt management is very important to prevent mortality and morbidity. Thank you so much for listening.
Thank you very much, Dr. Ekele, for that excellent presentation. We are really grateful. The floor is open for comments, questions, clarification from the participants, please. Participants, comments, questions, and clarification. You can raise your electronic hand to indicate if you want to talk. Thank you. Comments from the participants? Dr. Ekele, it means you did an excellent job. It seems everything is clarified. People are not raising their hands. I don't know if we can have some comments from those that went for these exams to tell us their experience and how the station went.
Hello, hello, Dr. Fatima.
Yes, sir.
Okay, sorry, I just wanted to say something too.
Yes,
question
sir.
seemed like it was very directed, okay? And I felt the speaker should actually follow that direction, okay? It's a man that had a stroke, looked like hemorrhagic, and then, of course, he has a history of cocaine use and was diagnosed with hypertension a year ago, okay? We do know that cocaine use can cause secondary hypertension, and we know that, of course, cocaine use is also a risk factor that can lead to hemorrhagic stroke. So I felt that part of the investigation, apart from investigating the stroke itself, would include investigating that secondary hypertension and, of course, other complications of cocaine use as well. Because, of course, we know that apart from the cardiovascular system, it can affect the liver, can affect the lungs, okay, just to mention a few, okay? So I feel that it's a directed question, and then the investigations and its management should follow that particular direction. I don't know if they asked us to manage this young man, but I think that at some point in the management, we're going to have to deal with his cocaine addiction as well, okay? And of course, because he was mixing, I think, cocaine and marijuana, so instantly we know that he was most likely smoking the cocaine as crack, because crack can be mixed with marijuana and then smoked together. Okay, so we may have to look at it long, particularly as well, because of all the substances in smoking and stuff. Yeah. So I just wanted to just pitch that in. So when we're thinking about managing the patient, let's look at what may have led to the stroke and the reason why he has most of his problems as well. That may be a catch in the question. Thank you,
Thank
Dr.
you very much, sir, for that excellent contribution. Thank you very much,
Okay,
sir.
thank you, sir.
Any comment from the participants, please?
Fatima,
More comment from, yes, sir.
there are questions in the chat box.
Okay. I saw appreciation messages. Okay, there's a question from Dr. Atta. Thank you for the wonderful presentation. At what point do you introduce DVT or PE prophylaxis? Dr. Ekele. Dr.
Okay,
Ekele, did
so
you get the question?
for patients, they said especially for patients that are not, can you hear me? Can you hear me?
Yes,
Hello?
yes.
Okay, thank you so much for your question. It said especially for patients who are not ambulant. As for patients with stroke who are not ambulant, you should do DVT prophylaxis. So you can start with intermittent pneumatic compression stockings, or you can use a TED stockings for that. And then when you do early physiotherapy, that's also a prophylaxis for DVT. But I think there's a slide I put that I didn't really, let me see. There's a place where they mentioned for patients with acute spontaneous ICH with proximal DVT, that's those who confirmed who are not yet candidates for anticoagulation. The temporary use of a retrievable filter is reasonable as a bridge until anticoagulation can be initiated. And I said for patients with acute spontaneous ICH with and proximal DVT or PE, that's when you've confirmed, delaying treatment with low molecular weight heparin for 1 to 2 weeks after the onset of ICH may be considered. But for all patients who are not ambulant, you should do some form of DVT prophylaxis, either using the intermittent pneumatic compression stockings or the TED stockings. Okay, thank you.
Oh, yeah, thank you very much for that excellent response. Dr. Chukwu John, you can unmute and speak, please.
Okay, good morning, senior colleagues and colleagues and teachers. I'm Dr. Success, sorry. I had issues with my phone, so I had to log in my husband's device. Sorry, because I had issues with my phone, I didn't hear many of the presentations, but I just wanted to say one or two things. Dr. Ekele, you said that ICH is also known as hemorrhagic stroke. That's not true. Hemorrhagic stroke is actually a type of ICH, okay? And so hemorrhagic stroke mainly has two types, ICH and SAH. Okay, so it is not the same type, it is actually a type. Talking about anticoagulation in hemorrhagic stroke. Now, routinely, we don't anticoagulate patients with hemorrhagic stroke because of course, we know the risk of more bleeding and worse outcome. However, there are some guidelines, you know, like when we presented hemorrhagic stroke, we are shocked to know that there are some guidelines that say we can actually anticoagulate after 4 days, okay? So, but you routinely, it's after 2 weeks to anticoagulate, but then you need to weigh your risk, okay, of why you want to anticoagulate a patient with hemorrhagic stroke. Then you talked of doing random blood glucose in acute hemorrhagic stroke. Now, apart from the fact that you want to check if the patient is diabetic or not, it's also important for us to note that hyperglycemia in acute hemorrhagic stroke can actually worsen outcome. So you also want to check that, okay? And I know that you talked of rehabilitation in managing your patient. Okay, this is important. So apart from the physiotherapy you are doing, you also want to rehabilitate your patient. This patient, takes, illicit drug, and of course, you want to, as much as possible, see what, you want to do and help that patient, regarding that. I'm not sure I heard any other thing. This is small I heard. Thank you so much for the presentation. It was great.
Oh, thank you so much.
Thank you very much, Dr. Success, for that excellent contribution. From the chat box, Dr. Afolabi is saying, thank you for the excellent presentation. A multidisciplinary approach is also an important aspect of the principles of management, which involves the neurologist, neurosurgeon, mental health team, anesthetic team, physiotherapists, nurses, etc. You got a lot of commendation from the class. Thank you very much, Dr. Ekele, for that excellent presentation. I don't know if there are more comments from the class or from our teachers.
Dr. Fatima.
Yes, ma'am.
I think Chief Chitu and the other participants have said everything, but I must commend Dr. Robert. He did very well, came on time. He's not going for this exam, came in before 7, and she delivered. I think there were just few comments from the neurologist, and I must also appreciate Dr. Success for coming in to fine-tune some of the things from the specialist angle, so that if this question repeated, you already know that you had what Chief Chitu said, had what Dr. Success said. There's no how you can get 100% in that question. So I must appreciate everyone for their comment. Thank you.
Thank you very much, Ma. Dr. Ekele, well done, and thank you very much once again. You can share your slide, please. And please, is anyone ready with his presentation so that he can immediately share his slides? Who is ready with his slides, please?
I am ready to present, but my slide is not ready yet. Can I present without the slide sharing?
Wow.
Does he have a slide up?
Hello?
Hello,
Yeah,
sir,
Dr.
do you have a slide?
My slide is not ready at all, yes.
Oh, we need someone that his slide is ready. We only do that if we're just starting the discussion this year. We want to start with a full of no slides. We need the slide. We're recording this. We need the slide so that participants can quickly revise it, and also we want to encourage sources so that others won't follow suit. So any other person that has slide, please, we will be making it an announcement so that we can answer as much as we can today. Please. Is there any other participant with slides?
Dr. Anthony, Dr. Florence Briggs, Dr. Obiamaka, Dr. Faboyinde Olabisi, Dr. Rahim Yusuf, Dr. Ugo, Dr. Olufi, Dr. Obasi. Please, who is ready with his slides?
My slide is ready, but just that I'm up for another presentation somewhere. So I'll present tomorrow. I'm presenting somewhere, about to present somewhere right now. So tomorrow I'll present mine.
So from the national group, from the group that were given November 2023 NPMCN exams, Dr. Godia Andrew, Dr. Adesokan, Dr. Abimbola, Dr. Orogun, Dr. Jeremiah, Dr. Victor, Dr. Edward, Dr. Tanimu, Dr. Eke, Dr. Mustafa Abdurrahman, Dr. Sani Abubakar. Please, who is ready with your slides? Hope it's not going to be a bad start.
Dr. Fatima.
Yes, ma'am.
Chief Kukima is in the house. Chief Chito is in the house. Let them make their comments. We posted this thing earlier now so that we could prepare our slides. And
Yes,
most of these people that took these topics, most of them are not new people. I avoided giving people topics. I wanted them to see how we present first before they start presenting. So most of them are old hands. So they know how we do these things. So really there's no excuse. Chief Chitu, sir, Chief Remigus, Chief Cook.
Good morning, Dr. Cookie. I understand that the people are not ready again. And we talked about that. I think there was somebody that said he was ready to have slides. I think we can take him and then we can send the slides later. We can, today is the first day, so we can now well, get angry from tomorrow. Yeah.
Give you to that. When you are supposed to holler, you'll be doing gentleman. For me, this is not acceptable under any guise. We've been talking about this thing. It's not acceptable. I don't know why we are doing this. Please, because I would defer to Dr. Shitu's judgment, because he's I know he's a wise person, he knows what he's talking about. But please, this will not be tolerated again. Thank you.
Okay, good morning, everyone.
Good morning.
Yeah, so it's unfortunate what happened this morning, but what I would just advise the participants is, once you are given a topic, even if you are number 10 on the list, please just prepare your slides. Because you know the saying that procrastination is the thief of time. So you may think that, oh, there are 9 people before me and it will not get to my turn. So unfortunately, some instances could occur. Maybe somebody can be sick or have something more pressing, and the people before you will not present. So you may be the only person left. So please let everybody just prepare their slides. Once you see your name on the roster, just prepare your slide like you are going to present it the following day, so that it's flowing. It's flowing. We have barely this. If you've been a member of this class before, you will find out that if we don't keep up, we won't be able to finish revision, and the aim will be defeated. Some sets that we did not revise continuously like this, it affected them. And that's the truth. It affected them. So please, let's keep the ball rolling. We're just starting. So let's all be prepared so that the class can flow. Thank you very much.
Thank you, Ma. Based on our chiefs and recommendations, please, Dr. Siri, you can go ahead, but please help us with the slides as soon as possible. Thank you, sir.
Thank you very much. My apologies again for not having that slide. It will sound funny, but the truth is that I saw this thing for the first time last night. Last night after our presentation around 11 p.m. I'm sorry about that. My apologies. I'll get the slide ready as soon as possible, please. Question number 3. A 52-year-old man presented with 2-day history of upper GI, upper abdominal pain. The pain started insidiously, dull in character. Dull in character, and located at the upper abdominal towards the center. The pain has been unrelenting in the intensity, gradually worsening, reaching 8/10 threshold about 8 hours after onset. The pain radiates to the back, worsens by food, and relieved a bit by sitting up. He noticed his body has been warm since yesterday, but no chills and rigors. No change in bowel habits. He moves bowels usually once a day. He feels a bit breathless on exertion, but no autopnea, PND, or cough. He took antacids without relief. He is a known hypertensive and diabetic on telmisartan 80 mg daily and metformin 1 gram daily. And his GP told him both, excuse me. And his GP told him both diabetes and hypertension are well controlled. He was never admitted in the past. He takes 3 to 4 bottles of beer per day, and sometimes takes hot drinks since his final year in secondary school. He never smoked, married in a monogamous setting with 3 children, no multisexual partners. Now, in this history, we notice that this patient is a chronic alcoholic that takes about that has been abusing alcohol since early in life. That is his teens, probably in the teens or from the third decades of life, and is currently 52. Developed this sudden abdominal pain that is worsened by eating food. Hello, sir.
Hello.
Can you hear me? Yes, sir.
Sorry, but I'm not sure I've heard the questions. Because you started explaining. Have you read out the questions?
Okay, sorry. I've not read the questions. Okay. What is the most likely diagnosis? List 2 investigations necessary for the diagnosis of this patient. List 6 etiologies of this condition. What is the principle of management of this patient? Okay, so this patient has upper abdominal pain that is made worse by food. It made worse by food, and a chronic alcoholic that's been on for since he's probably his third decade. That's since he was in university. And we equally know that hypertensive and diabetic. Looking at it, the hypertension and diabetes, I couldn't correlate it very well. Maybe that was a distraction in the question. But what's the most likely diagnosis? After looking at the question, I thought that the diagnosis is gastric ulcer, considering the fact that this patient's pain gets worse with feed, unlike the duodenal ulcer that would have got better with feeds and worsened by hunger, expectedly. Of course, the differential diagnosis will include duodenal ulcer, acute cholecystitis, acute cholangitis, acute myocardial infarction, and acute cholelithiasis. Now, the investigations that could be done here will include upper GI endoscopy and possibly biopsy, urea breath test, and fecal antigen for H. pylori. Now, plain chest X-ray will be necessary to rule out possible perforation where we see air under the diaphragm. We can as well do angiography, but this can be positive if we use this can be positive if the ulcer is bleeding at a rate that is greater or equal to 0.5 mils per minute. Then the etiologies. Etiologies could include previous history of peptic ulcer disease, drug uses like special abuses like use of NSAIDs. This man is about 53, so he's even entitled to have osteoarthritis. Drug abuse of NSAIDs, steroids, use of tobacco, and of course, H. pylori infection. Of course, lifestyle, which includes tobacco abuse, alcohol, and stress could predispose to this. Now, we can have a hypersecretory state like antra-GI hyperplasia, then hyperparathyroidism, uremic gastropathy, Crohn's disease, allergic gastritis, etc. Then now, principles of management. Hope I'm not missing anything. Yes, principles of management. The number one principle is that we suppress peptic acid secretion, suppress the gastric acid secretion by administration of protein pump inhibitors like omeprazole, or administration of H2 blockers like cimetidine, even though that protein pump inhibitors is better. We equally aim at H. pylori clearance, where we administer antibiotics. Then we try to reduce the acid concentration in the stomach by administration of antacids. Then we may administer ulcer crater covers such as sucralfate And of course, we'll counsel this patient against the habits of abuse of alcohol and abuse of alcohol. I think essentially that ABCDE. Thank you very much.
Thank you very
Hello.
much. Yeah. Thank you very much, Dr. Cyril, for that wonderful attempt. It's a nice one. At least it's better than not having it. The floor is open for comments, clarification, and questions. Thank you. Yeah, Dr. Kopi, you can unmute and speak.
Thank you so much, Fatima. Thank you, teachers, and thank you, Dr. Uzoki. We went for this exam, not really a question or a clarification. I just want to suggest, since this is an exam question, and it's very that will go to, I still think that Dr. Uzoki should be given the time to make slides for the sake of the people, because I think I did from first. Not really what was that the exam and how it went. So if you say we want to attempt to make contribution on what he did, we might end up glossing over this important question, and if it's repeated, I don't trust that he can get his slides ready, do some background homework on this question, and then the gastroenterologists on the page, the ones going for exam, can also contribute. Thank you.
All right, thank you very much for that suggestion. Dr. Ibrahim Halad, you can unmute and speak.
Good morning, everyone. Thank you so much, the presenter. Despite the short notice to you, you are able to present. Thank you so much. But from my side, what I think my first diagnosis, I will consider pancreatitis. Looking at the history of ethanol ingestion for a significant time, I think we should consider pancreatitis as the first differential or as the first diagnosis. Then we consider PUD subsequently. Thank you.
Yeah, thank you very much for that addition. Dr. Marianne, you are raising your hand.
Yes, good morning, my seniors and colleagues. I was going to make the same comment because when you read the clinical scenario, my mind went first to acute pancreatitis, but he didn't even mention it in the differential. So I just wanted to point it out. Thank you.
All right, thank you very much. Dr. Chuku John, you can unmute and speak.
Okay, thank you so much. It's me, Dr. Foster. So I agree with the acute pancreatitis, and I think the STEM also led us to what the most likely diagnosis would be. And so the two investigations that are necessary for this patient, most likely if you're managing pancreatitis, we'll consider serum amylase and serum lipase. Then the etiologies, we use the code I get snatched, okay? G for gallstones, and A for E for ethanol, which is alcohol, and a strong risk factor, okay, that for acute pancreatitis in this patient. Then others, steroids, trauma, tumor, autoimmune, if all the H's, hyperlipidemia, hypothermia, hypercalcemia, and also some medications like tetracycline, azathioprine, and sulfonamide, including anti-seizure medications like valproic acid. And so for the principle of management, we want to remember our, or for the goals of, we want to remember our ABC of resuscitation, Now, as much as possible, we want to try and see how we prevent or identify and prevent complications in these patients. And of course, for this patient that is a chronic alcoholic, we want to also rehabilitate the patient, because the patient goes home and keeps taking alcohol, so the pancreatitis, of course, at the end of the day, may not abate. So these are my small contributions. Thank you.
Yeah, thank you very much, Dr. Success, for that excellent contribution. Any more comments from the class? From the chat box? Yeah, main differentials. Main differentials are acute pancreatitis and perforating peptic ulcer disease. Thank you very much. Someone is saying, what is against acute pancreatitis? I don't know, is that a question? Dr. Hereford is saying, thank you, sir. I think acute pancreatitis is the main diagnosis. Patient demonstrated Van Zandt sign. Most likely diagnosis is acute pancreatitis, the man chronic alcoholic, pain relieved by sitting up and pain not relieved by antacid. Yeah, Dr. Atta is also saying, thank you for the prompt attempt. Most likely diagnosis is acute pancreatitis, is has risk factor, and the upper abdominal pain is typical of acute pancreatitis. Differentials could be perforated peptic ulcer, perforated gastric ulcer. So thank you very much all for the comments. Any comment from our teachers, please?
Sorry, Dr. Fatima, good morning. So still for diagnosis of acute pancreatitis, abdominal CT also has a very important role to play. And among amylase and
Sorry, we can't hear you clearly. Your voice is low.
Okay, hello. Am I audible now?
Yes,
okay.
better.
I was saying for diagnosis of acute pancreatitis, abdominal CT also plays an important role in addition to the serum amylase lipase concentrations. And we should remember that lipase is more specific than amylase. Thank you.
Thank you very much for that excellent addition. So comment from our teachers.
Fatima, let the participant comment. This is a class. We have a lot of gastroenterologists here. If they're done, then our kids will come in. But let the participants make as much comments as they can. You see, Dr. C, when he started, was moving stuff, but he realized that from the comment and he found that he didn't get the diagnosis. So in this question, you notice once you miss the diagnosis, you might not be able to answer the other question really. So this is the purpose of this class, is to train you on how to answer questions, because I'm sure in his mind, he aced the question really. Beside the slide, he did well, but from the comment, he's beginning to realize that he missed it all together. So let them continue to say everything in your mind, say it. There's somebody here that will correct you that please do. This is not how it is again. You never can tell. So that you keep it to your mind and go to exam and start saying it in exam. So please, participants, more comments. Thank you.
Hello, good morning.
Yeah, morning. We can hear you.
Sorry, I just have a comment regarding one of the I think comments made by the presenter that in the question it was mentioned that the patient is a non-hypertensive and diabetic, and the presenter said he thought that was actually a distraction. I think it's not a distraction; it's also a clue. Since we know that the diagnosis is likely to be acute pancreatitis from the presentation, the patient being a non-hypertensive and diabetic is likely to have dyslipidemia. And dyslipidemia is also one of the risk factors for pancreatitis, as we know. So I think that particular part is not a distraction. It's also to give us a clue. It's also another clue to give us that the diagnosis is likely to be acute pancreatitis. So meaning that the patient is likely to have dyslipidemia. The patient is also a chronic alcoholic. So these are clues, risk factors for the acute pancreatitis in the patient. So it's another thing to tell us that it's likely to be acute pancreatitis. So that is actually not a distraction. It's also a clue for us to get the diagnosis. Thank you very much.
Thank you very much, really. Thank you very much, everybody.
Thank you very much for that excellent addition. Thank you. More comments from the class?
for want of time, I think we'll just I don't know, we'll take comment from our teachers, then because we need to elect our class rep for this season, especially for West Africa. We need to do that this morning. It's almost 8. So comment from our teachers. Chief Chito, Chief Remigus, Chief Cookie.
Yeah,
Chief Cookie is
it's
done.
me
Yes,
once
sir.
again. So I just want to commend the presenter. I mean, this is what this class is all about. Is for you to make your mistakes and learn from your mistakes. So just as they've said, the diagnosis is acute pancreatitis, and everybody has mentioned what are the things in keeping, because there were so many clues there. The fact that he has this pain after eating, and you know that the pancreatic enzymes are released with food. So that's why the autodigestion will cause the pain. And then when he leans forward, the pain is relieved. So the Atlanta classification says that the pain is relieved on leaning forward, and then there's abdominal CT findings of acute pancreatitis, and then the serum amylase and lipase are 3 times upper limit of normal. So when the patient meets two or all of these criteria, then it's in keeping with acute pancreatitis. Then the fact that the patient is a non-alcoholic, and then the patient also has diabetes. So there were so many clues in there, and that is how this exam goes. This is no longer part 1 that someone will tell you to define this, define that. This is not part 2. This is not what is obtainable in part 2 level. So in part 2, you'll be given a clinical scenario, and it is left to you to read in between the lines and understand everything, and then you look at everything holistically. So what diagnosis can encompass all the symptoms and signs that were given to you, and then you now look at the differentials. So that's why we encourage us to participate in this thing, so that you can now start reasoning in that line, and when you get to the exam hall, it will be a walkover. So I want to commend you and then tell others to keep it up. Thank you.
Thank you, ma. Thank you so much, ma.
Thank you very much.
Dr. Siri, thank you. Thank you so much for the effort. We appreciate your courage. Thank you. Let us all learn from Chief Siri's mistake. We posted this thing since last week, I think Wednesday also. And Dr. Siri will be communicating on WhatsApp, so I don't know how you didn't see the message we posted on part 2 group. So please, just once in a while, check the group. Make sure your name is not anywhere, or make sure there's no vital information. This is how people just miss vital information. Make sure there's no vital information be shared there that you need for the fellowship examination. Just check once in a while, just scroll through. It doesn't take so much time. Once they just scroll through, maybe at night. Now you miss anything. So thank you, everyone. Thank you for the contributions from the gastroenterologists. Thank you, all the presenters, Dr. Robert, Dr. Siri. Thank you so much. We appreciate you. All the contributors who appreciate you. Are there Dr. Kopi, Dr. Fatima? Thank you so much for your consistency. We are not releasing you guys. You are just handing over to the next class. But please, you guys are not handing over. We're begging you, don't disappear, please. You continue to help to coordinate and coordinate the class. So thank you so much today, Dr. Fatima and Dr. Kopin. I appreciate you. So please, we want to elect the new class rep for this season, class rep and assistant class rep. Please, we need a volunteer. Please, let's keep it fast. We have 4 minutes to 8. A volunteer before I'll soon go through the participants. Please, nobody should hide. Nobody should log out, please. A volunteer, please. A male, a female, anyone. I was class rep for my time, so it mustn't be a male all the time. A male, a female is fine. But you must be going for this April, this March exam. Please, a volunteer. People are logging up. Chief Chitu, Chief Kukima, and Chief Remigus, do you have anyone in mind? Dr. Copy, anybody in mind?
Yes, ma. Thank you so much for this opportunity. Having given the opportunity to be class rep, I've identified someone that has the potential if he's available to accept it. And I think he will do a great job. Dr. Okute Atta
Okay, I think I
is
saw him.
vibrant. Yes, vibrant. I was chief resident. He took over from me and did great job. And he's on this page. He's going for the exam. He's a
I can
leader
see
in
him
his
already.
rights. He has the capacity. He has the capacity. We'll just plead to him for him to help the class. It's a gastroenterology to the core, and he's a good man. Thank you.
Dr. Okute, sir, please be our class rep. You've been elected.
Good morning, everyone.
Good morning, sir.
Good morning, everyone. Dr. Okopi, you have set me up, but it's all good.
It's good setup. It's good
yes,
setup.
It's all good. Yes,
it's good
it's all
setup.
good.
Once you
Yeah.
sacrifice, check it out. All the class rep, they don't have issues.
Yes,
Not
yes.
because
So
they are all, everything. When you sacrifice, make sacrifices, God look at your sacrifice and just really mercy. You understand?
Yes.
So please, you should actually
I
appreciate him.
Yes, I accept, and thank you for nominating me.
Thank you,
and
sir.
God bless
We
the class,
appreciate
and
you.
I wish everyone success as we go through these classes. Thank you.
Thank you, sir. I don't know. Are you joining for the first time, or you've been observing? Because ideally, we usually give you.
Yeah,
You've been observing.
I've been around. Yes, I've been observing.
That means from tomorrow, you take over.
No problem.
Yeah, we're not leaving you. Dr. Kopi is
Yeah, no
around, Dr.
problem.
Fatima is around, I'm
problem.
around, our other chiefs are around. So
No
we'll
problem.
still
No
guide
problem.
you. We'll guide you.
He was a key contributor in that book I made. That I did.
Are you serious?
Yes, he has been on this page for almost 2 years. So
and he has been very quiet. You see how life works. Anyway, I'm happy he was participating behind closed doors. That's what matters. Thank you so much, sir. We appreciate your contributions even before knowing you. Thank you so much, sir.
You're welcome.
Thank you.
Yeah, thank you for the privilege once again.
Okay, I think we have a class rep. Let's be thinking about the assistant. It's 8 already. Let's close the class. Chief Cookie, Chief Chitu, please help us close the class.
Okay, thank you very much to the wonderful presenters and to all those who participated in the class. So I know that for a number of us, this is our first time joining this class. So I hope you are seeing the way the class goes. So please just as an advice, once your name is up to present, as in once you've brought out the list, please prepare your slides. Don't say that I'm number 10 or I'm on the second page. Even for the national, everybody's slide should be ready. Because when you prepare it in time and you also go through it, it gives you opportunity to even revise what you wrote. And that would make you better in that topic. Okay, so participation is very important. So I encourage everybody, ask questions and also read. So don't just come to be spoon-fed. This is not the class for it. So everybody should also go through the questions, the question paper, and also jot, so that when they are teaching, you can look at what you read, and where there are lapses, you fill in the gaps and then ask questions in areas that you do not understand. So this beautiful news, I want to wish each and every one of us an amazing and a blessed day. We meet again tomorrow. Stay blessed. Bye for now.
Okay, good morning. Good morning, Dr. Cookie. Long time no see. Long time no speak, more like.
Well done, my brother.
Yes, ma'am. All right. So Dr. Cookie has basically said everything. Please, let's try and participate. We've seen the structure of the class. Please, let's try and conform with it. As I pointed out in my the bulletin on submission of dissertations for dissertation presentation, please, I'm going to take that into consideration before I put up the name. Usually I create a timetable and just put everybody's name on it. But if I don't see you participating in the general medicine class, then I wouldn't put you up for dissertation class. Because here, we don't want people to be going back and forth in the exam. We want you to do your general medicine, pass your dissertation, pass your everything and go. Okay? So please, I'm going to take that into consideration as well. And that was something myself and Dr. Christabel had discussed. Because some people, we don't see them during the week, but suddenly they want to present the dissertation on the weekend. No, we won't do that. Unless it is somebody that only has dissertation to go and present or something, then we can make special consideration for the person. But please, let's participate, okay? Tomorrow is another day. Let's be here early. We have a new group rep. Congratulations. Please note, group reps don't fail. So, in other words, you have passed already by becoming the group rep. I don't think there's a group rep that failed. So, please, let's assist our group rep to make his life a lot easier. Okay? All right. So I wish everybody a wonderful morning. Tomorrow is another. Good morning, Dr. Christabel.
Morning, sir. Thank you, everyone. Thank you, our teachers, our participants. Thank you for coming to class. Have a wonderful day. Dr. Fatima, please help us close the class. I made you the host.
Yes, ma'am. Thank you. Yeah.